welcome everybody. Thanks for joining in our inaugural webinar discussing Introduction to Occupational Environmental Medicine. It's a pleasure to have people join in, and I can see people still joining in. We have an increased interest from overseas. Me and John Schneider are both based in Australia, and I'm based in Sydney. John's based in Mackay or Cairns at the moment?
Mackay.
It's a pleasure to see people joining in from overseas, from all over the world. Thanks to all the participants who are joining in with us from overseas, from the Middle East, Africa, Southeast Asia. It's a pleasure to have you, and also all our fellows, colleagues and registrars joining us from Australia and New Zealand. Today is the 21st of April, 2023. It's a pleasure and a delight to have Associate Professor John Schneider with me today to discuss about, to do an introduction on occupational environmental medicine. It's probably more than an introduction. And before we delve into that, I'll probably like to share more about John Schneider. I've had the luxury of being a student of John Schneider over 10, 15 years ago. And to this day, I've been involved, and I continue to learn a lot from him. I'm a consultant in Australia, and me and John both are also fellows of the Australian faculty and also of the Irish faculty as well. So I'll give a quick introduction on John before we go into the slides. John Schneider is an associate professor at Mackay Clinical School. He's been affiliated with the James Cook University Faculty of Medicine, Health and Molecular Sciences. He holds memberships of the Australasian College of Tropical Medicine and Safety Institute of Australia. As I've told you before, he's also a fellow of the Australasian Faculty of Occupational and Environmental Medicine and the Irish Faculty of Occupational Medicine. He's been an examination coordinator for the Middle East for several years and is currently a member of their examination committee. He's also on the faculty assessment committees with the Australasian faculty. John graduated from the Queensland University and obtained a graduate diploma of occupational health and safety from Curtin University. Initially in his life, he practiced as a family physician and later as a consultant in occupational medicine in Northern Australia, mainly in the mining and agriculture sector and their associated services. Up till 2013, he worked at the Institute of Public Health in UA University, where I met John for the first time, lecturing in occupational medicine to both undergraduate and postgraduate medical students and vocational OHS practitioners and students. John has had an exciting career. He's been involved with the Health Authority of Abu Dhabi and other oil and gas industries in the local area. He's had the opportunity to go out into the Middle East and do various sessions, workshops, and seminars face-to-face in Iraq, in the local Middle Eastern communities, and also in India. And he's widely attended various international conferences and done several research papers. John returned to Australia in 2014 and resumed his medical education to James Cook University as an associate professor until 2023, where he's recently transitioned into part-time practice. He's currently actively working on a part-time basis and is quite keen on education, and hence why the opportunity to have John on board with us today. His main areas of interest are occupational health in rural and remote work sites, workplace rehabilitation, ergonomics in particular, working in hot environments, where I've seen John publish actively a lot and consulted to various organizations overseas, and postgraduate education in occupational medicine and health. So that's a very brief introduction of a legacy I know personally. So over to you, John. We would love to hear from you.
Thank you, and welcome everyone, and particularly to some of my former acquaintances from the Middle East. I gather we have a few here today. Now, hopefully everything will work all right. I'm getting a little bit of a note now and again that I've got an unstable connection to the internet. with luck we'll get through it. That's just our starting slide. So Farhan, if you want to move on to the next one. And the aim of this is to just make sure people are aware of the sort of work factors associated and relevant to work-related ill health and injury. Next one. Yeah. This one was interesting. It was a graveyard. Oh, can we go back to that? Yeah, a graveyard I went to in Scotland, actually, and I saw these tombstones. And it made me start to think that work is, and has for many centuries, been relevant to individuals. You can see 3 different headstones. No problem with language here. And the only thing that's on them, from what I gather, is the occupation of the person that's buried below. On the left, there's one, probably a carpenter or a mason. The one in the middle is a baker, and the one on the right, the very elaborate one on the right, must have been from a very well-to-do farrier, someone handling horses. So they're all very old, probably before a lot of the people buried there had the opportunity to go to school and gain some literacy. So from that point of view, Tom the farrier or Bill the baker, and that was how they were known amongst their own conditions. So work has certainly been something very important in the lives of lots of people in the past and indeed in the present. If we can move on. Good. The objectives we're just running through. If we can move on to the next one. Well, what's occupational health? And this is from the ILO and Workplace Health and Safety, the World Health Organization, I mean, published in 1950, and it hasn't changed much since then. Promotion and maintenance degree of physical, mental and social well-being in workers in all occupations. Next one. And that includes the effects of a person's work on their health. And next one. And also the effects of a person's health on their capacity to work. Next. So that fits in nicely with the core medicine, the core business of medicine, where we're managing or approached by the general public and our patients to help them manage perceived risks. And that fits in nicely with general risk management. And the steps in that most of you hopefully will realise are identifying the hazard, assessing the risk, determining the controls, and then assisting with implementing the controls, monitoring the effects of those controls, and from time to time reviewing the overall process. Next one. What we've got is a hazard, which is a situation or a substance with the potential for causing injury, damage, or loss of an asset. And risk is really a determination of the probability of loss as a consequence to exposure to the risk. And it's something that lots of people get mixed up about, is they talk about risks when they're really talking about a hazard. Risk really involves determining the consequences and the probability that something nasty will happen. There are lots of hazards around the place, but of course, if people aren't exposed to them, there's no risk or adverse consequences. Next one. Thanks, Fuzzy. So, if there is exposure, what we need to do is determine the risk, and to some extent that depends on the dose, which is a factor, if you like, of concentration or time, and then the consequences of that. Next. And there's many ways of doing that, but a semi-quantitative one that I've found pretty useful, not being a statistician, is looking at this risk assessment matrix. And there are several of these. This one is nice and simple. If you're involved ones that are available on the internet if you want to, but it's something to carry around or to refer to if you're doing some form of risk assessment. Next one. Talking a little bit about who's involved in occupational health. The hygienists come in, and they're helpful for us when we want to quantify something, and which is also very useful if you want to get nice hard information on exposure and the nature of the exposure and the concentration. So they're involved in hazards, identifying and confirming the hazards, and putting figures on the concentration, if you like, particularly physical, chemical and biological hazards that are around. And also they play a part in exposure monitoring, both pre and post controls. In other words, helping recognise what the hazard is, if it's a chemical or something that can be measured, confirming that in the environment, and then quantifying it, evaluating it, and monitoring it to make sure that it's been removed or that there's some process taking place that reduces the risk. Next one. If you like, occupational and industrial medicine looks a bit of that and applies that to the worker. And also to do that, you need to have some sort of awareness of the workplace. The other thing is, with the hazards that the worker is faced with, the occupational physician or occupational health worker also needs to be aware of psychological factors and social factors, which often aren't considered by the hygienist or chemist that's associated with things. And again, with exposure management, both pre and post control that we'll talk a little bit about later, recognising the hazards, confirming it's present, treating the exposed people, and treating the workplace where we may be wanting to do something about removing or reducing the exposure, if possible, eliminating, and then monitoring and preventing other people from doing. So The traditional medical practitioner often just treats one patient. The occupational physician usually needs to get involved with treating the workplace as well as the worker. There's no point in, like a patient I saw only a few weeks ago with a carpal tunnel syndrome that was exposed to considerable hand-arm vibration, went along to his GP, got a referral to the orthopaedic surgeon who decompressed his carpal tunnel, sent him back to work. He came back later on with a recurrence of the symptoms. So what he did was referred him on to another orthopaedic surgeon who injected cortisone into his carpal tunnel, sent him back to work, and everything was all right for a couple of weeks, and then he started getting the same symptoms again. So in a lot of situations, you really need to consider the workplace and make sure that the hazard has been eliminated or treated there. There's no point in treating symptoms without treating the cause of those symptoms, as hopefully everyone attending this meeting is concerned about. And the management of the risk, we use the hierarchy of control pyramid that's also on the internet. The best control, of course, is elimination. Remove the hazard altogether from getting rid of the exposure to the hazard to the worker. If not, we can substitute something else that's not as hazardous if necessary. Engineering controls, perhaps to isolate the worker from the hazard. And there's a lot going now, artificial intelligence and robotics in the workplace. If not, we can look at administrative controls, and that may mean rotating staff around to reduce exposure times, or failing everything else, personal protective equipment. And hopefully, as everyone in this webinar is concerned, everyone here recognises that personal protective equipment is the least important and the least effective of all those sort of controls, because you've done nothing about the hazard. If the hazard is still there, then there's exposure, but you're relying on something else to limit that exposure or mitigate the exposure or relieve it. If there's a failure in that, of course, you're going to be exposed again. Next one. The objectives, we'll talk a little bit about that now. If you could move to the next slide. Okay, bringing in public health. And it's probably better to think of occupational medicine and public health together, because if there's in a significant number of workplaces, there are more than one worker in the workplace. And then, so there may be several people that are exposed to the hazards. And the one that we pick up first, of course, is that who's either had the biggest exposure or is susceptible to adverse effects from that exposure. But we need to keep in the back of our mind all the time that what you need to identify is, are there more than one people being exposed? So we're looking at the working public in that situation. If we can move on to the next. The basic requirements for good health in a population are access to clean water, good food, shelter, clothing and health. And that's where the public health and preventive medicine comes in. Next one. And that's what we're looking initially is in occupational health, but there are other factors that we look at if we look at the whole environment. Next. Okay, so you can see, because there's so much involvement in hazards in the workplace and workers' health, there's a necessity for often multidisciplinary teams to get involved with expertise from particular areas. We've already talked about occupational hygienists, but there are a lot of other people involved. Next. The employers, the organisation that the person is working for, and intervention from that sector, other workers, unions, governments in making policy and hopefully policing policy, the judicial system, particularly when there's some problems that can't be dealt with, or some concern about whether they've been dealt with adequately enough, workers' compensation insurers, and the general public. And we've got to remember that in a lot of workplaces, there's interaction with the public, and the workplace may be providing services to those people, and they, in that situation, they have an obligation to provide safe interaction or safe products. Next. Okay, so the involvement, as we said, it's multidisciplinary. Hopefully, if you've got a good situation, you've got access to trained occupational health nurses, hygienists we've already mentioned, clinical psychologists, toxicologists, ergonomists, looking again at the systems in place in the workplace, physiologists, health and safety managers, epidemiologists, health physicists, microbiologists, safety engineers, sociologists, and lawyers, of course, if there are problems arising to manage those hazards. Next one. Okay, so a brief history. Occupational medicine, if you like, goes back to Hippocrates when he's considering the health of people. And it was recognised centuries ago that occupational and the occupation and the environment is relative to health. Agricola came around in the 16th century and identified that in his publication on the mining and metalliferous industries, that miners frequently were found to be short of breath and dying prematurely. And there's one case he described of a widow who'd outlived 7 husbands who were involved in gold and silver mining in the Czech Republic. It was interesting when in Queensland and Australia at the moment, dramas about exposure to silica dust in the mining environment and in other situations where silica dust can be produced, as if that was something new and something we didn't know anything about. And here it is, it's in the literature 500 years ago. And frequently this happens. People get used to working in a unhealthy environment and exposing themselves to risk. And the more you expose yourself to the risk, the less you perceive it as being a risk, unless someone has some adverse consequences of exposure that they've come across. And that's what we're exposing now. It's not a new disease, it's not a new problem, it's something that's been known about for centuries, but people haven't continued with their ongoing management of risk and prevention. And then in the 1700s, Bernardino Ramazzini in Italy published the first textbook, if you like, of occupational medicine. And one of the quotes from that, of course, is when a doctor visits a working class home, he should be content to sit on a three-legged stool if there isn't a gilded chair, and should take time for his examination and question the patient. The questions recommended by Hippocrates, but he should also add one more question, and that's, what is your occupation? As we said, that's a possible consequence of many hazards in the work, many health and injury conditions that can occur in the workplace. Next one. Okay, so work as a cause of disease and injury. Moving on. This is some data, and I find using epidemiological data is something we need to be more and more aware of, and we need to make our actions and explain our ideas and recommendations using epidemiological information. And this is getting a little bit old, but it's reasonably good information published by the World Health Organization. 2.3 million people die from work-related accidents or disease in 2008. And that's over 6,000 deaths a day. So it's a big problem worldwide. What we need to be aware of, though, is the next bit. How many of those died as a result of work-related illness? Next one. And if you look at statistics and workers' compensation data, particularly where I work, you'll find that the biggest reported health issues from work are usually associated with traumatic injury, burns, broken bones, cuts, other forms of trauma. Whereas if you look at the overall health data, again, and as I said, this comes from the ILO, 86% of those deaths are due to illness, not injury. Injury is easy to determine and easy to be aware of, and usually someone's been around to see what's happening. Illness causing death from work-related conditions often happens over prolonged periods of time with gradual deterioration in health. It's something because it comes on slowly and the person may be moving from one occupation to another. Those situations, unless the medical practitioner is aware of it and asks the questions, are often overlooked. Next one. So, what's occupational medicine about? In particular, there's a clinical aspect that you get involved with. As we said earlier, prevention is important. There's no point in sort of, if you like, picking out the person with the problem and forgetting that there are often other people involved. You need to get involved with environmental factors as well as the industry. You need to have some knowledge and awareness of medico-legal issues, often asked to give your opinion whether work could be a causative factor in a medical condition or an injury, particularly one that results in disability. Again, some background in public health. And the other factor that's often forgotten is the military situation and the health in that area. And I know in many countries overseas, particularly not so much in Australia, but occupational physicians are often employed within the military and have an involvement there to make sure that those workers are fit and healthy and can deliver the goods. Next one. So we need some sort of expertise and awareness in the diseases that are common to particular occupation. We need to be aware of disability resulting from injuries and illness in the workplace and the rehabilitation or management of that, hopefully getting the injured or ill worker back into a situation where he can resume productivity in the workplace. You need to have some background in toxicology and particularly a bit of the chemistry of hazardous chemicals that may be found in particular workplaces. You need to have an understanding of occupational hygiene and the data that comes out of hygienists and interpreting that appropriately, ergonomics, industrial safety issues and how health and safety is managed on work site. Epidemiology, as I said, is particularly good to give you some background and awareness of what the common hazards are and what have you. You need law background and some idea of legislation and regulations in that area, and then management, including planning, policy development, absence management, workers' compensation and industrial relations issues. And they can all be sort of dragged into a management situation if you're dealing with the management in a particular workplace and that working situation. Next one. Medical treatment itself, as we're aware of, primary treatment is usually first aid, and in hazardous situations there's often first aid data around the place that it's available. Secondary treatment is usually more specific to what's going on and may involve admission to hospital or attendance with a medical practitioner, or even surgical procedures or medical procedures. And the third issue or step in medical treatment is rehabilitation. In other words, helping to manage impairments which result in disability and hopefully with a view of getting the injured or ill worker back into a productive work situation. Next one. Okay, so I realise that we've got a very diverse audience here, but hopefully in most countries and situations there's some form of insurance, medical insurance, covering people who experience illness or injury in the workplace. In Australia, there's a statutory requirement for insurers, either with a government insurance company that provides that service, or some of the bigger employers, particularly the multinational ones and those practicing in various states and jurisdictions, may be self-insured with their own insurers. There's a government regulator in Australia anyway, and the aims there of that insurance is to cover the cost of healthcare, to provide income replacement services if the patient is unable to work because of a work-related illness, in situations where there is a permanent impairment that can't be repaired, if you like, then frequently there's access to lump sum payments through some form of assessment. Now, so there's advice, compensation on various benefits, and you may be involved with talking to patients about that. One of the things that I find difficult in Australia anyway is trying to get people to understand the difference between impairment and disability. And that's put forward in the World Health Organization. They've published it, where impairment is loss of a function of a particular body part or bodily function, and disability relates to how that loss of function affects the capabilities and the capacity of that injured individual. You can see on the left slide there, that's a person with a very obvious impairment. He's lost his leg, and it was a patient of mine when I was looking after an amputee clinic at the local hospital. And he got very frustrated after he lost his leg and couldn't wait to see a prosthetist. So he made his own prosthetic, which you can see underneath, out of this guy was a boiler maker, so he was used to dealing with steel, and he had a steel sort of peg leg, if you like, with a hinge, so he could bend his knee, or the artificial knee, and the stump was encased in a lamb's wool sleeve. So very, very practical, functional outcome. And you can see on the right something a bit more up to date and a bit more modern. And that person again has a significant impairment with loss of a limb, but his disability is situational and it varies from what he's doing. And in that situation, he's riding a bicycle quite competently and safely and has that capacity. So we've got to realise that the impairment may be looking at loss of function of parts of the body, but often that impairment, the disability arising from that can be managed or overcome. So impairment and disability are two different things that hopefully, for those of you that are medical practitioners, we can sort of make people aware that that's the situation, that impairment is probably not the best measure of the effect of a person's injury or illness. Disability is more significant as far as the worker's capacity to do particular tasks. Next one. Yeah, what we're looking at is corporate occupational medicine, something that's disappearing from the Australian situation. I know when I started my occupational medical training, one of our big multinational companies employed 14 doctors full time. It's now just released their last full-time medical practitioner, and it's probably going to go the way of a lot of other multinationals where they contract out the medical services. So they're relying on someone that they hope has a close enough affinity with their workplace and can do that. Farhan, we seem to have...
My apologies. I think I scrolled the mouse too much there.
Yeah.
So where were we?
Yeah, keep going. Yeah, next one. Yeah, there. No, back. So, you know, there's... When I was overseas, back again. Just one slide back.
Sorry, there you go.
Yeah. So with corporate occupational medicine, I think it's much more frequently found in a lot of overseas situations, particularly in big corporate entities working in countries where basic medical services aren't perhaps as accessible or comprehensive. And in a lot of that situations, medical practitioners and healthcare practitioners find themselves employed directly by the organisation. And that certainly has some benefits in awareness and knowledge of the workplace and the work situation. And you can, in that situation, you can often get yourself involved in advising on health and safety risk management issues, particularly where prevention is involved, and general public health. You can get involved in hazard identification and health risk assessment, policy and procedure development, hopefully as a company representative involvement in the legislative and regulatory compliance and process by governments who often, frequently, if they're like Australia, don't have a lot of expertise within their own organisation. And now, and what's an area that's becoming more and more important from the corporate point of view is corporate social responsibility and the perceived involvement of big organisations in the healthy management and provision of safe working places. The other corporate thing that you can often get involved with is control of sickness absence and getting involved with that early, intervening early in managing the absence, and preferably early return to work and early resumption of appropriate duties, which is something that often doesn't happen if that's left to someone else to do. We often see, and I still see, people who've been off work for 6 months, in some cases even 12 months, because they could have gone back to work with appropriate selected duties and in situations where they're no longer exposed to the hazard, but they're not. They don't get back to work. They haven't had any involvement with work, and work hasn't made some sort of awareness of what they can provide to the worker or his medical practitioner. The other situation you get involved with, of course, even if you're involved in industrial medicine, is environmental health issues, as we'll talk a little bit about later. Often it's the same problems that people in the workplace experience, but all that's happened is the hazard has drifted over the fence and it's now affecting other people that live in the environment surrounding the workplace. And the other thing you can get involved with is advising on product or the safety of services that are produced by the company that the person works for. Next one.
Hi, John. Just wanted to remind you we're at the 45-minute mark.
Yeah.
Great, thank you.
We'll try and speed through a bit. Okay, next one. So with absence management, we've got to remember that there's also presenteeism, and absenteeism is when the worker doesn't turn up for work because he's ill or can't do the job. But the other thing is we also get people who turn up for work who are not fit to do all their duties, or worse still, if they've got some sort of infectious disease, they may pass that problem to other people in the workplace. And that was particularly obvious in some situations with the recent problems that people may have experienced with COVID exposure, is people who turn up for work who pass on an infectious condition to other people in the workplace, magnifying the problem. The other thing with absenteeism, medical practitioners are often involved in, is justifying medical certification of capacity to work. And the situation is more developing to assessments of capacity rather than just blanketly saying that the person is unfit for work. Often they're unfit for particular tasks in the workplace. So some knowledge of the task and how people do the task is very important in that situation. The other thing that health practitioners may be involved with is attributing the work, whether it's an attributable cause to the worker's condition. If there is an attributable cause in the workplace, then in situations where it's available, usually there's some form of workers' compensation or covering costs of lost employment, what have you. And the other thing, of course, that you get involved with presenteeism, giving the employer or the workplace management some idea of how long temporary placements may be required. So if you've got someone who's got a situation where their illness is going to be settled down quickly, the existing working population may be able to look after that. The other thing is post-absence review. So once the person is ready to come back to work, that review is usually there to ensure that the person is fit to return to work, that he's not going to have another injury or aggravate condition that kept him off from work. So is he totally unfit to return to work? And as I said, that may be because of some infectious disease and a continuing risk from exposure to that. Or the other thing is, particularly workers who are in the food industry, are they going to spread the infectious disease they've got onto customers or other people that they're looking after? Provisionally, the other thing might be worthwhile is, can you go back quickly? If we next, yeah. The other thing is, if the person's not totally unfit to return to work, they may be able to go back with some suitable duties required. So the thing that you can get involved with there is rehabilitation requirements. do there need to be any adjustments made to the workplace? And that may be something as simple as providing a ramp for workers to get into and access their work site if they're using crutches or in a wheelchair. And the other thing to think about in that situation is there continuing medical treatment going on? Does the worker have to go back and see the doctor for more treatment or surgical, or have they been provided with medication? And if they've been provided with medication, is that medication likely to impact on their continuing employment? If they're given drugs for maybe painkillers or what have you, is that going to cause drowsiness? Is there going to be problems with the patient's cognitive capacity? Can they think properly, if you like? Can they make important decisions if they're under the influence of a painkiller or an antidepressant or a sedative type medication? Next one. The other thing that often medical practitioners get involved with, if they're involved with corporate medicine, is education and counselling. And that may be particular advice about hazards in the workplace and education and educating workers on how to look out for adverse effects associated with those hazards. Someone's working in a hot environment. It's nice if the workers can identify people who are having cognitive or physical impairment because of dehydration or other issues, or general health promotion, promoting healthy diet, exercise, trying to reduce non-work related hazards, particularly things like cigarette smoking. And that's very important in a situation where there are particular hazards in the working atmosphere or working environment. We all know the pathophysiology of effects of cigarette smoking. It can affect the cilia in the trachea, and that's one of the body's defence mechanisms against inhaled particulates. If that's not working, then it magnifies the exposure and the effects of exposure to respiratory hazards. Next. We've got another pyramid here. So health promotion and counselling. For those involved, just to remember that the smallest impact is on counselling and education in the workplace. Then clinical intervention and counselling at the time of clinical intervention is a bit better. Long-lasting protective interventions. Teach things like giving up cigarette smoke. As long as the patient gives up cigarette smoking, then he's improving and reducing the likelihood of work-related lung disease from exposure to hazardous particles. Make the patient's defaults, if you like, safer. Things like fluoridation of water supply, adding iodine to the diet in areas where thyroid disease may be a problem, reducing tobacco smoking in the workplace and reducing accidental exposure to other workers there. And the other one, of course, is socio-economic impact. So looking after and looking at poverty, education, housing, equality within the workplace, literacy, those sort of things have the largest impact. Unfortunately, a lot of that depends on government situations, but again, some of the big multinationals often look at some form of education and socio-economic equality within their workplace. Next. Okay. as we said, with our hierarchy of control measures, stopping the exposure. And one way of that is immunisation. So immunising people against infectious diseases, like maybe a lot of you were involved with COVID, particularly healthcare workers. The nature of their work is particularly hazardous, the same as people working in laboratories or research with infectious agents. Travel overseas as part of a person's job. They may be going to areas where other sorts of communicable disease are present, or the other situation is agricultural workers, particularly things like exposure to zoonotic medical conditions that may be carried around and spread by animals that they come in contact with. And all that, if we're looking at that, is looking at health maintenance and productivity of the workforce, and immunisation is a good example of that. Next one. Disaster planning, things that we're looking at, chemical spills, nuclear accidents, rail accidents, road accidents, terrorism and fire, all those areas you can get involved with workers. Interestingly enough, the picture in the bottom right-hand side is Chernobyl, and that's an ongoing issue from a disaster occurring in a workplace. Next one. Okay, environmental issues again, when the hazards are escaping from the workplace, the impact of emissions from the site, or accidental spills and emissions, and those fish and the fishermen on the right is the situation that occurred in Minamata, where there was considerable public ill health and consequences from escape of mercury from an industrial plant in Japan, with effects not just on the local workers but also the general population. Next. Again, we were talking about consumer issues, particularly in the food with food handlers and in the hospitality industry, and also product safety. If you look at the one on the right and look very carefully, you can see these are dish towels that were circulated a while ago, used in the kitchen, very handy to have with you, particularly if something on the stove catches fire. So what the company did, they added asbestos to the towels. Of course, we all know now that that wasn't a very smart thing to do, but things like asbestos can creep in around the place and get involved in even the home situation, as well as other exposures in the workplace. Next. Okay, so another area that you can get involved with is auditing and quality assurance, something that's not done particularly well in Australia or in a lot of Australian organisations, but hopefully overseas, where medical practitioners have a stronger voice. Compliance with internal and external quality standards, and there's a lot of international standards being publicised and promoted now. Review of the structure and process and monitoring health management and occupational health and safety programs, and benchmarking. So comparing yourself with a like organisation as a means of seeing how you're going and whether you're improving the situation or whether you're up with other standards. Next one. Factors contributing to disease. Next one. Okay, now we have, go back the old model, around the 1980s and prior to the 1980s was what we call the biosocial model of disease. There was an accident or exposure, people had an injury or illness, and that led to an incapacity to work. The other thing that was associated with that incapacity to work may be non-work related pathology of a physical or biological situation. Of course, once the incapacity starts, then there are other personal and environmental factors such as age and education and psychological background that may affect capacity to return to work particularly. Next one. Unfortunately, that back one, I think we've skipped one. The biomedical model was taught up to the 1980s. Nope, go on. That was right, and you can skip that one too. That's about people's perception there. Health factors affecting safe and efficient work performance. What I was going to get to before we go to that is the new model of health is a biopsychosocial model. And that's being adopted more and more, at least in Australian medical schools, where you're looking not just at the biological and health-related causes of conditions, but you're looking at things like social and psychological impacts that also have an effect on how the person reacts to his illness or injury. Unfortunately, a lot of the people who only have basic medical training, particularly those of my vintage who are getting on and went to medical school prior to the 1980s, got taught the biomedical model. Now, hopefully, or in Australia at least, in the medical schools that I've been involved with, the biopsychosocial model of illness is starting to get taught. It's still not widely taught in Australian undergraduate medical situations, but there are more and more medical schools that are teaching that model. And that's really looking at the injured worker themselves and how they're psychologically managing the situation and what their social support is like, and what they've got that can help them through those times. So getting involved with psychological support of the worker is just as important as sort of prescribing medication or undergoing and performing some sort of surgical procedure. Next. Okay, so the other thing that occupational physicians are often asked to do is medical assessment. And we touched on that briefly, but we've got, if you like, pre-employment or pre-placement assessment. In other words, is this person fit to do a job? And I say pre-employment or and I think we may have a few legal people around the place. And often the pre-employment medical is performed in some way to protect the employer about employing someone who may be a liability. The problem is, if you fail someone in a pre-employment check, are you discriminating against that person? Is he really unfit for work? So sometimes, and that can be a big problem if someone is not given a job that they've been promised because they failed their medical The next problem that may arise from that is litigation for unfair dismissal. The problem is the person hasn't been employed, so there's no duty of care on the employer to undertake a pre-employment medical because he doesn't have a duty of care to that worker until that worker is employed. So in those situations, if there are hazardous tasks involved that the worker is going to be possibly exposed to, then it's often better to refer to pre-placement medicals. In other words, the worker is employed and then assessed to see whether he can be placed in a particular job. So that's a problem that we will discuss in a couple of half a minute's time. The other thing about medical assessment pre-employment is, and it's useful because you can establish a baseline. What's the person's hearing like before they're employed and put in a noisy occupation? Do they have pre-existing lung disease? Is that going to be a problem if they've got respiratory hazards that they're going to be exposed to? So you can use your pre-placement assessment as well, if you like, to identify potential problems. And if there are potential problems or foreseeable problems that worker is going to be exposed to, then we can do something about monitoring that. If someone already has a pre-existing disability, or pre-existing impairment rather, is their disability going to be a problem? Is there reasonable workplace accommodation that can be made, modifying the work situation, adjusting the tasks that the worker has to do, or restricting certain situations that they may be involved with that may increase their risk of problems? So reasonable workplace accommodation may be something you're asked for assessment. As I said, the applicability of legal requirements. In some situations, particularly with high-risk workers or with workers undertaking high-risk jobs, there's often a regulatory requirement for those people to undergo pre-employment assessment. And in that situation, you've usually got the backup of the regulator if there's some dispute over whether people are fit or unfit to do a particular task. And the other assessment of fitness for work, maybe after the person's employed, is do they have any current situations that need to be monitored, and what's their long-term prognosis like? Is it a situation that may get worse and deteriorate over time? And in that situation, then some form of ongoing assessment, medical assessment, may be required. Next one. Okay, the other thing about fitness for work and the traditional fitness for work that I see provided by lots of GPs and requested by lots of employees, is it cost effective? Is it discriminatory? My professor in the UAE did a survey of several thousand pre-employment medicals undertaken by the National Health Service in the United Kingdom, and they looked at 3,000 or 4,000 sort of employment medicals, and the people that were considered unfit for work, I think, was less than 100. So the employer spent lots and lots of money on doing medical assessments, which really didn't help them all that much. And the other thing that we talked about, is it going to be discriminatory? Is someone going to lose a job because they've got an impairment that someone thinks they can't work with? And the guy that's shown here is an ex-Air Force employee that lost both of his lower limbs in a aircraft crash. It had nothing to do with his military situation. It was recreational flying. He was involved in a crash, lost both his legs below the knee, and he now is working for the Flying Doctor in Tasmania and flying quite capably. Before his job with the Flying Doctor, when he was still in the Air Force, he used to pilot the Prime Minister of Australia around in his personal plane. So there's someone with what most people would consider an impairment that would prevent him from undertaking particular jobs, but it certainly didn't increase the risk of injury when he was flying an aircraft. Next one. Someone else who was given 2 years to live in 1963. And as a consequence of that, he was immobile, had significant discussion, problems with communication, but he managed to revolutionise physics for the next 50 years or more. A good illustration of impairment and disability, and why, if we're giving people large sums of money, we should be looking at spending that money perhaps on people with significant disability, not impairment. If we're going to treat impairment, we should treat impairment with the money, and use the money that impaired people get as a lump sum payment to fund proper rehabilitation and return to work programs. Next one. And the last one, of course, is the importance of getting an occupational history and a walkthrough. Next one. So what we need to do, and what a lot of doctors doing occupational medicine don't get the opportunity to do, is go out and assess the workplace, have a look at it. Walking around and doing a walk around the workplace, you can often recognise several hazards that are there. That helps you evaluate patients who come in with medical problems. Recognising the hazards, but also doing an evaluation of the risks. As we said before, is there exposure? If there's exposure, what's the concentration, or how significant is the hazard, and what's the probability of the risks? If there's no exposure, there's no risk, even though there may be a significant hazard that people are involved with. And the other thing, of course, is recommendations for control measures and monitoring and review. This guy on the right there was welding, and his protection from welding flash was a piece of paper stuck behind a pair of sunglasses. So not only did he not really protect himself terribly well from welder's flash, but he ran the risk of having a fire in his face. Next one. Okay, so we mentioned a little bit about post-employment or periodic medical assessment. And that's when your health surveillance and health assessment is targeted. So we know the hazardous exposures, we know the chronic and medical conditions that can arise from exposure to that, so we can assess how those at-risk people, whether they're starting to show signs, or we can use biological monitoring to test exposure. So urine testing to see whether people have metabolites of hazards that they've been exposed to in the workplace in their urine. So that is a situation where you know what you're looking for. Pre-employment medicals you often don't know what you're looking for. You're just looking at a person's health, and you don't know the situation that they're moving into. It's difficult to produce any useful information. Whereas this, if you know what you're looking for, you're testing for what you're looking for, you can inform the workplace that, yes, this person has been exposed, so they need to do something about it, or no, there's no evidence of exposure. And that may indicate that the hazard has been successfully managed at the workplace. And again, as we said, there are some situations with safety critical work where there's a requirement for people to do post-employment medical, usually periodic, done every 1 year, every 5 years. That depends a little bit on what the situation is and what the person does. But people like pilots, train drivers, firefighters, or people transmitting dangerous goods are particular ones that most of us get involved in from time to time. Next one.
John, we've got some interesting questions coming through.
Yeah.
Would you like to
Well,
go through
maybe
them now,
we'll
or-
call it quits in the environmental and public health area.
Okay, sure, no problems.
So we have that may be something that we can do later on.
No worries. So what I'll do, I'll probably go through the questions. There's some interesting comments that have come across. Thanks for that descriptive, detailed presentation and the dedication that come across. I've got a question here from Andreas Breitbart. Thank you for an informative presentation. 2 questions if you have time. What do you feel are currently some of the shortcomings of OEM practice in the Australian context? And what do you foresee the future will be in developed countries for occupational environmental medicine, particularly for environmental medicine? Thanks.
Yeah, so the first one was in Australia, in the Australian context. Unfortunately, my practice, like probably a lot of other special occupational physicians' practice, is seeing people who've already got problems. I think in Australia we need to focus more on prevention, and companies need to focus more and more on preventive measures rather than waiting for a problem to occur and doing that. Too much money is wasted on unproductive and ineffective fitness for work assessments, where it doesn't have a lot of good.
Sorry, we lost you there, John. So while John comes back, I'll just go through the next question as well. We've actually probably lost John over there, but I might just carry on until John comes back. I think the future of environmental medicine is what we're really looking forward to. Occupational medicine has been well developed in developed countries. In Australia, it's environmental medicine where we can see a lot of deliberation and a lot of progress happening. I think we probably lost John there, but until he comes back, I'll probably help out with the questions over here and read out a few comments that we have received. Yes, the presentation will be shared afterwards. And their questions: how do I learn more about occupational medicine, educational opportunities in Australia? And there's a question here from Malaysia as well. I'm Dr. Shawal from Malaysia. Can I know where can I further study more on clinical occupational medicine with regular exposure, specific ward round and clinics for occupational disease cases, multidisciplinary team approach, tertiary referral center? Is there any such facility available in any country? Thanks for your question, Dr. Shawal. So in terms of the scope and opportunity in Australia, I think there's plenty of an opportunity for work when it comes to occupational medicine. You do need to go through your relevant accreditations while you come over to Australia, but we do offer a facility, and that's something John was going to touch base later down the track. And I think John is coming back on. He should be back here shortly, but hi, John. We lost you there briefly. And we would be really willing to offer you any such opportunity. I'm based in Sydney, and John is based in Mackay. But with our educational endeavors, we would like to offer opportunity for further training for overseas doctors. However, that's something we can have a chat about in the future. Mind you, there's a huge difference between practice in Southeast Asia, Dr. Shaval. So you're based in Malaysia and in Australia. I've been to Malaysia several times, but it would be very interesting for you to see and visit us and see how the scope of practice is diversified within private and public sectors in occupational environmental medicine. Shifan's comment, nice and detailed presentation. When will you hold more sessions like this? Yes, we are really looking forward to holding more sessions in the future. We will make this as a regular occurrence as well. Dr. Schneider, I think we got you back. I was just going through the questions that were coming through here and helping out. We had some questions from Malaysia and questions about more future opportunities for occupational environmental medicine in Australia and the scope of practice. John, are you there now?
Yeah. Can you hear me?
Yeah, I can hear you, John. So you're nice and clear. I'll address the next question to you now. So a question has come across from Dr. Ali Hussain. Very nice presentation, Professor. Currently based in Abu Dhabi and work as an occupational physician in oil and gas industry. So thanks, Dr. Hussain. Thanks for your compliment. Dr. Hussain Mawanga, great presentation. I'm in Tanzania. I've noted that some employers are more interested in well-being rather than occupational health itself. What is your experience on this? Thank you. Thanks for that. So that's to you, John. Thanks. So I think John's probably struggling with internet issues, but nevertheless, I'll carry on with those questions there. So Dr. Hussain, thanks for your question. Nice of you to join us from Africa. Yes, I agree with you. There's a preventative approach with well-being rather than occupational health itself, but a part of occupational health is about well-being, health and well-being and promotion of it. So it is public health in the workplace, as we like to call it. In our experience is that when there is a proactive preventative approach by the employer, it actually goes a long way, and it does speak volumes. So employers who are more focused on well-being do tend to assist with intervention when it comes to injury management down the track with health surveillance and toxicology. But nevertheless, I think your question is more peculiar with your background. I might not have answered your question, but our understanding in Australia is that health and well-being, preventative medicine, public health goes hand in hand with workplaces. I might get Dr. Schneider to answer that question when he's back. I'll go through the next comment here. Great job, Dr. John and team. Your content was relevant. Your format was visually appealing and easy to understand. Thanks for your comment, Patricia. Dr. Vishwaraj, excellent webinar. Thank you, Dr. John and Farhan. Regards, Dr. Vishwaraj Mahal Shekhar from India. Thanks for your comment. Muazzam Zaidi, nice to see you. Thanks, Muaz Al-Hadi, excellent presentation, many thanks. Excellent presentation, many thanks, Muaz Al-Hadi. Thanks for that. I'll probably carry on because our presentation is still ongoing. I'll carry on to the next phase before we finish off tonight. And my apologies that Dr. Schneider was unable to join. We'll probably carry on this presentation in our next phase. There's a lot of content that he wanted to share. and we'll come back to the questions when he's back on track. But what I wanted to talk about today was discuss about our concept and our initiative in offering you education through our portal Med Education Online. We really like to promote occupational medicine education across the world globally. Australia has been a pioneer. We do have strong curriculum and we have a strong training program. It's an Australasian faculty, Australasian meaning it comprises of Australia and New Zealand, two countries combined. We offer a very detailed, staged educational program for training registrars. However, noting the developments in our neighboring countries, me and Professor Schneider would like to offer you further insight. And I would like you to visit our website, mededucationonline.com.au, which will provide you significant opportunities in the future for further webinars, sessions as well. If you have a look at my website as well, our website, you would see that there's an option to subscribe and also details to say that we are launching soon with further content availability for online education. And this will provide you an opportunity to learn online relatively easily in the comfort of your own space. But it will also provide you opportunity to connect with myself and Professor Schneider in the future. And also have opportunities to possibly visit us and observe our practices. The mission that we have with our endeavor is to promote occupational environmental medicine, occupational health and safety globally. So the audience over here is not only medical practitioners, but health professionals alike, which includes nurses, or any other allied health professionals, EPs, physio, occupational therapists, even health and safety managers in the workplace. The audience is relatively open, but our dedication and focus is to medical professionals overseas. And Professor Schneider has a fair bit of collegial support overseas, and I think with his time spent in the Middle East, some of you have known him and seen him present in the past as well. We would like to share that me and John Schneider would be presenting on a practical workshop at the Australian New Zealand Society of Occupational Medicine, ANSOM in Canberra this year. You are invited to attend. It's an international organization. It's an annual scientific meeting being held in Canberra. On the 24th of October, myself and John will hold a workshop from 2 p.m. onwards, which will be a practical insight into the basics of occupational medicine and give you an opportunity to learn hands-on and get more experience. Some of you who might not be aware, you could register on this website on the link below, which I'll share later on as well. You're more than welcome to come and join us. The society does have a full-on condensed program which runs for several days with worksite visits and exposure to all developments in occupational environmental medicine across Australasia. So I would be really glad to see this be a regular occurrence, and we catch up furthermore in the future with more events with other colleagues, in particular with John Schneider. And we look forward to seeing you face to face if there's an opportunity to come and join us in Canberra. So John, I hope we have you back again.
Yes, we have unsettled atmospheric conditions here and a bit of thunder around the place. So
okay.
I think that's interfering with the transmission.
Sure. There were a few questions that I would like you to answer. So we've had a question from Dr. Shawal from Malaysia asking about opportunities in Australia in clinical occupational medicine and to see the multidisciplinary approach and also anywhere else outside Malaysia where they could go to.
Well, Malaysia, I know the Irish faculty runs exams in KL on a fairly regular basis if they've got enough attendees. So it may be worthwhile, and they also run examinations in the Middle East. So they've got 3 examination sites that people can go to get an internationally recognised qualification and peer assessment. Unfortunately, in Australia, we tend to focus on medical practitioners and registration of those practitioners within Australia. So there's often a residency requirement, and there's a requirement for training depending on what your background is. So that's something to think about, but the Australian New Zealand Faculty of Occupational and Environmental Medicine website and the Irish website are worthwhile seeing and having a look at, and that will give you some indication of what goes on. There is a benefit, I suppose, in having one of those qualifications because they are internationally recognised. So it probably would help people wishing to work in occupational medicine for larger organisations and multinationals to have that sort of background and qualification. But as I said, different organisations have different requirements. Most of them have an exam at the end of that. And then there's a number of universities in Australia that offer health and safety training, not necessarily for medical practitioners, but it does give you a bit of an insight and background to health and safety management at work sites. And that's a part of a requirement for the Australasian qualification. But that's as much as I could give. There's opportunities for occupational medicine in Australia. Unfortunately, a lot of those occupational medicine opportunities are offered by corporate medical providers who really don't have a lot of background in occupational medicine themselves, and you end up doing pre-employment medicals and poorly management and ineffective health surveillance programs. So you've got to be a bit careful about where you work for and the sort of work you're going to get. It's probably better talking to an Australian colleague and getting some information off them before overseas people try to rush here. As I said, the situation in Australia is from the very good to the very poor in occupational medicine, but there's not a lot of opportunities in corporate medicine, unfortunately.
So Warren has passed on his message as well, and appreciated. It's a great introduction. So thanks for your comments, Warren. So as you would not be aware, Warren Horrocks is the president of the Australasian Faculty of Occupational and Environmental Medicine. He is the current acting president, and we appreciate his time that he's been here with us today. I've had a few questions coming through from Dr. Ali Hussain in Abu Dhabi, who works in oil and gas. He's inquired whether there are any opportunities in Australia after LFOM, Irish exams. And an earlier question he had was, so earlier he introduced himself, and that's his question. John, thanks.
Yeah, well, the LFOM is certainly useful at getting a position, but it's not a specialist. It's not a recognised specialist qualification as far as the Australian health system is concerned. It will probably serve you well as background if you're going to do get an Australian qualification, but it certainly won't allow you practice as a specialist, although there may well be in positions that are available to you that wouldn't be available for someone with no background at all.
Right. We had a question from Dr. Hussain from Tanzania, and the question was, which I tried to answer earlier. A great presentation. I'm in Tanzania. I've noted that some employers are more interested in well-being rather than occupational health itself. What is your experience on this?
What were they interested in?
So the question is, employers are more interested in well-being rather than occupational health itself.
Well, occupational health is certainly part of well-being, and the two are related, and that's why we tried to marry occupational and environmental health together. I mean, if patients are well and looked after well, then their productivity is going to be a lot better. The thing about employers is employers probably have more of an impact and are likely to have more of an impact on work-related hazards and exposure to that, and risk management or health risk management from that perspective. Certainly the health risk assessments that you can get involved in doing may help identify problems within the process at the workplace. As I said, you know, general public health and general health and well-being are certainly worthwhile, but often, you know, a lot of employers don't look at that and allow things, certainly in Australia, the worker themselves to manage their healthcare.
Yep. So Dr. Hussain, thanks for your questions. I can allow you to have a chat if you want to. I've just turned you, you can unmute yourself and ask if that answered your question. Happy for you to join in this case.
Hello, thanks. Thank you for your presentation, John and Farhan.
Thank you.
So you know, I'm from Tanzania. So in Tanzania, you know, the regulation is not as strict. So when you're approaching an employer, if you want to kind of work on a program, like for example, looking at the musculoskeletal disorders, or you want to do a risk assessment, or you want to do an exposure assessment, then because they're trying to save the cost, so they probably tell you that, you know, the employee would be more interested if you come with a program looking at the prevention of non-communicable diseases rather than the typical occupational hazards. Okay, so that's kind of been experienced here in Tanzania. Thank you. Thank you for your replies. Yeah.
Thank you.
Yeah, thanks, Hussain. Of course, different situations in different countries vary, and often in Australia, certainly where there is very great regulation on workers' compensation for work-related injuries and illnesses, that can be a fairly significant financial burden on the employer if people are having injuries. But where labour is cheap and plentiful, I'm afraid there's often not much incentive to prevent things. The only thing that you can point out is, I mean, if there are major injuries happening in the workplace, then that interferes in itself with productivity. I mean, if there's serious industries in mining in Australia, that can shut down the whole mine for several days, or at least to a situation, and the first aid is implemented. So reduction in productivity may be something that may be worthwhile considering pointing out to employers. That and absenteeism and finding people, the more skilled the workforce is, usually the harder it is to find replacements. And even if you do get replacements, then they really, unless they've worked in that environment before, they don't have the awareness of regular employees. And if they don't have the awareness of regular employees, they're at increased risk of having accidents and injuries. So you can argue around and round in circles, but the better trained and the healthier the workforce is, the better the productivity, and the less productivity is going to be affected by injury and illness at work.
John, we've got Dr. Ali Hussain, I think, wanted to speak up as well. He's from Abu Dhabi. Dr. Hussain, Ali Hussain.
Yes, Ali.
Yes, Dr. Farhan and Dr. Professor, thank you for your valuable time, and it was a very good presentation. Learned a lot of insight about the practice of occupational medicine in Australia. I have been actually working in this oil and gas industry, and I also happened to work for a little time with the late Professor Tarchi, and he was the executive for occupational medicine in ADNOC, and have learned a lot of insights to occupational medicine, which got me interested to take this exam of licentiate, which I took recently, and I'm looking forward to take the membership. And definitely want to enhance my scope of practice moving to Western countries, because that will give me more, education about the real occupational medicine. And that's the reason I asked this question about the scope of practice in Australia, which is very informative, and which really the professor has answered well, that definitely licentiate is just the beginning. It's not specialization where I need to do my membership. So is there any scope after membership in Australia, or I still need to do some training in Australia?
You would still probably need some training in Australia. Australia doesn't have licentiates and doesn't have membership. They only have fellowship. And that's because of the way our health system works, is you're either a specialist or a non-specialist or a trainee. And the system of specialist training is developed particularly for the Australian sort of health system. New Zealand is a little bit different. I also worked with Professor Tarching when I was residing in Al Ain. And I don't know whether you know Dr. Moazzam Zadi, but he moved to New Zealand, and entry to New Zealand is, and their medical system is a little more easily to join than the Australian system, and they do recognise Irish qualifications a little more. It depends how, it does depend in Australia how much experience you've got. You may be able to work as a specialist under supervision of another specialist until you've either passed another exam or accumulated a certain period experience.
Thank you, Professor. Thanks a lot for your answer. It was very valuable, and I hope to work on it in future.
Thanks for that. So I'll just quickly go through because we got a few questions coming in. Dr. Abdulaziz, would you like to speak up? I've seen your question come in as well. Dr. Muhammad Abdul Sattar Abdulaziz. The question that came through from Dr. Abdulaziz was, I'll probably read it out. Do we have references or standards to test done in periodic annual health assessments of welding fume exposed workers? He's asking for biological tests, and I think he's asking for guidelines as well. John, would you like to guide to safe work or anything similar?
Yeah, Australia's had in the last 10 years, I suppose, a review of their regulations and requirements. Unfortunately, Australia is composed of 6 different states, and up until not very long ago, each state had different requirements. Everything has been sort of tended to be reviewed and is still in the process of developing national standards. But Safe Work Australia may be an area to have a look at if you can get online and do it. But otherwise, you know, there are a lot of online resources now for health standards and for and the US has lots of stuff too. And I think now that the UK and the European Union are developing standards as well too. So there are standards around. They may vary from place to place. And I think, I'm not sure, where are you practicing, Mohammed? I know that the UAE were developing their own standards and requirements some time ago. And I assume that they've
yes, Dr. Mohammed, please.
Yes, thanks, Doctor. I'm practicing in Egypt. I'm Egyptian, and I'm an occupational health specialist. And sometimes I've been working around in mining and building materials, petrochemicals, and oil and gas. So whenever I go to a new business, I try to search for the annual health assessment standardized tests. So I cannot find it in one place with the same shape. So usually I use the international regulation for it, yes.
Yeah, I think if you don't have local requirements and regulations, at least if you perform assessments that comply with European Union standards or then that's probably better than nothing. Unless you're working and doing work for a large multinational, then the really big multinationals usually have their own health and safety procedures and protocols, and they're often based on where the head office of the company is, whether it's in Europe or it's in the United States.
Okay.
Great. So I think that answered that question. We had another question from Malaysia. Occupational noise-induced hearing loss is #1 disease. Is occupational noise still a problem in your country? So I'll pass that on to John, but the answer is yes.
It certainly is. And it's a big problem in the mining industry where I work. But because it doesn't kill people, it doesn't get a lot of lot of publicity, and it's largely being ignored. Like a lot of things, the issue is dealt with by the media and gets on television, the politicians do something about it. But if it doesn't, you know, they're quite happy to live in blissful ignorance.
Right. So I think we've come to an end on the questions today. We've had some great comments come through. I think one comment that stood out is how to get further opportunities, training, and experience in Australia. And also if this would be repeated again in the future. So John, while we lost you in the middle, I did discuss with the audience about our plans on the website development for online modular delivery and also our workshop in Canberra on 24th of October. And we are hopeful, it's a hybrid event, and we're hopeful to see more people there. I think that's it from me now, John. Was there anything else you would like to add on?
No, apart from the bit of technical glitch and the time it took to get through that presentation, it may be worthwhile doing another shorter one and talking about international recognition and qualifications, and catch up with what we didn't get around to with the public health.
Really appreciate your time, everybody. It's I note we are getting around to 2 hours. I really appreciate your patience in sticking around and spending time with us. And we hope to see you again in the future. As mentioned earlier, please visit our website, Med Education Online, and be tuned to see further developments come in. We will send you a copy of this presentation today. And if you could make it to Canberra on the 24th of October, we would love to see you there face to face. If not, you could attend it by hybrid and as an online attendance as well for a hands-on workshop. I appreciate the time, and wherever you are in the world, good morning, good afternoon, good night. It's definitely good night for us. Thanks, John, for your time today. I really appreciate it.
Good. Thank you very much. And if anyone that I've met in my past life is still there, have a good April and good luck in the years to come.
Great. Thank you. Goodbye. Thank you.
Yeah.
Cheers.